To give you a quick overview of what we do at the RWJF Center, we're a health policy research center that's particularly focused on increasing the number of minority PhD students that focus on health disparities research, specifically racial and ethnic health disparities. So as you'll see from Dr. Nikora's talk today, we train researchers, particularly at the PhD level from the social sciences, to go in, whether they're in academia or applied policy positions, to try to eradicate racial and ethnic health disparities. That, in a nutshell, is what we do at the RWJ Center. So any students in here, you'll see we have a table outside with information in regards to recruitment. I'll give you a quick sales pitch. So one of the things that we provide at the RWJ Center is a pretty generous stipend to provide you with resources so you don't have to work a full-time job while you're trying to get a PhD. But probably more important than that, statistical support, writing support, and a community of scholars across disciplines that all focus on these issues of racial and ethnic health disparities, whether it's psychologists, anthropologists, political scientists, jet plane fighters, whatever it is, we come at it from a multiple of a different range of options. So if you're interested in learning more about us, we have a table outside. You can grab some information or tag me after the event. I'd be happy to talk with you more about that. So this particular lecture, if you're not aware of it, is Homecoming Week. So we have an ongoing lecture series at the RWJ Center that you can check out on our website. Our next speaker will be David Wetherington. So we have a speaker series where we bring in folks to talk about these issues of racial and ethnic health inequalities. In the context of Homecoming Week, we wanted to do something special and actually bring back one of our alumni to come back in the context of homecoming, welcome him home back to UNM. Dr. Nikora here is actually a former student of mine, political science PhD, relatively recent graduate, whose dissertation work, as you'll learn more about, focuses on infant mortality, particularly racial differences in infant mortality and the way that structural discrimination plays into that. So we're bringing Dr. Nikora back to us from Beloit College, where he's an assistant professor, a relatively young assistant professor there at the university. And I'll say as one bit of backdrop for Dr. Nikora before I turn it over to him, on the job market, he will probably be the only student that I ever had that batted 1,000. Literally applied to only one job and got it. And it's an extremely great fit because, as you see in his bio, he's specifically in the health and society program as well as political science over there at Beloit. So without any further ado, I'll turn it over to Dr. Nikora. Right. It's a great pleasure to have you back. With great pride, seeing one of my own former students here to speak here at UNM is a blessing.
Awesome. Thank you. Thank you much. Great. Appreciate it. I'm going to grab my water, and then I will dive right into it. One thing I will say, I am now very much comfortable with the role of being a teacher, being a professor. Some of you who know me know that I should be because I talk and I talk and I talk. So it's sort of a perfect fit for me in multiple ways, including in the way that Gabe mentioned already. I also want to thank the center for bringing me here, and I want to thank the fellows for asking for me to come. I couldn't have been more surprised, and I am very grateful that you chose to give me the opportunity to come here and talk to you a little bit today. Now, I also want to warn you a bit. I'm not really much for standing behind lecterns, so if you were expecting a speech kind of like this, you know, and all you have to do is listen, there will be a lot of listening because, again, I talk a lot, but there will be interactive parts to this. So I know you didn't think that this was going to be like a class, but this is going to be a lecture that's more like a class. So I'm going to ask you for your responses, ask you questions, and be prepared to answer, okay? There will be a quiz at the end. All right, so let me grab my little doohickey here, and we'll get right into what I wanted to talk about. And I do take this to heart. Let's talk about embodiment, considering internalized trauma in U.S. health disparities. Gabe and I on the walk over were talking about this word disparities, and in truth, I actually like to use inequalities, but I'm going to continue, at least for a little bit, to use the term that the federal government tends to use more often than not. So there's a question that I want you to keep in mind as we sort of talk today, and it's this. What is the impact, or where's the impact, rather, of history and trauma? And what do I mean by trauma? Because I'm assuming everyone knows history. You know what history means. But when I say trauma, I'm talking about any event, any set of circumstances, any conditions of life that could be construed as injurious either physically or psychologically, to the human body. Okay, I'm sort of defining that in this broad sense. So in order for my later discussion to make sense, we're going to have to spend quite a bit of time talking, I think, about infant mortality. I'm not sure how many of you are really familiar with infant mortality. It's kind of what I do, and we can talk a little bit later about why I'm so interested in this. But I'm going to tell you some things about infant mortality. So, the infant mortality rate. Well, what is it? Well, it's a global measure. It's used by the CDC. It's used by the World Health Organization. And, of course, it's used by the OECD as well, the Organization for Economic Cooperation and Development. And what it is this measure of infant and maternal health. But it's actually more than that. Almost every definition of infant mortality talks about infant mortality and to a lesser extent maternal mortality being important measures effectively of societal health. How well is your society doing? And if you really think about it, it makes sense, right? Is that a society can be measured, how well a society can be measured, can be measured based on how it treats arguably its most vulnerable citizens, right? So this is why it's used as a global measure, and that is why it's an important measure as well. So in the United States, in 2009, the infant mortality rate for the entire country, 6.04 per 1,000 live births. Okay, we measure infant mortality per 1,000 live births. For infants that are born to African American or black mothers, that rate was 12.3. And for those born to white mothers, it was 5.3. Now here's the thing. The racial gap in infant mortality that we see today, because you can, even those of you who, like me, are not super good at math, you can sort of do a quick multiplication, and we're talking about what? 2.5 times, right? In 1920, take a guess. What were we looking at in 1920? What do you think? 1.2. It was close to that. It was about 1.7, right? Kind of unbelievable, huh? So, of course, the rates themselves have improved over time, right? I mean, probably the infant mortality rate in 1920 was something like, for whites, I think 70 per 1,000 live births, and for blacks it was about 100 and something along those lines. Of course, those rates have improved, but the gap between them remains and has actually worsened. Before I show you that. So when you think about infant mortality and where we're more likely or less likely to see it, I always had this sort of idea in my head that certain states would be where you would see infant mortality rates higher or lower. Now, this is your first quiz. What states, and just by a show of hands or you can just blurt it out, it doesn't matter, what state do you think infant mortality would be the worst for blacks, for black infant mortality?
Alabama.
Okay, Alabama, Mississippi, okay. Louisiana, okay, excellent, excellent. Anyone else? Anyone want to throw Toledo, Ohio in there? Anyone? No one? No one? Okay, all right, well, that's what I used to think, right? You think the Old South, you know, still has a very high African American population. You know, there's poverty, there's racism, all of that good stuff that we assume, yeah, should be impacting infant mortality rates. Well, when we look, and these are the most recent data that I could get. This is from a period from 2007 to 2009. The average, you can see here, this is the green are your 10 lowest, and the red are your 10 highest. When we look at black infant mortality, oh, there's Alabama. Oh, wait a minute. Alabama, Mississippi. Oh, the red ones. Who is this? Arizona. What do we have here? Wisconsin. That's where I'm at right now. And we can talk about that later on, okay? Very serious problem with black infant mortality, and actually white infant mortality as well in the town that I'm in. We've got here Michigan, Indiana, Ohio. See, I told you. I told you. I tried to warn you. Right? The only place, in fact, that's in the traditional Old South is where? Tennessee. And they're really a border state. They were a border state, really. Okay? Look at this one. Kentucky. They're green. Kentucky is one of the 10 best in black infant mortality rates. Okay? Now, let me tell you a little bit about what best and worst means in this context. Now, I've neglected to mention Washington, D.C., okay, because I tend to focus on states. In the research I did, really did focus on states. But Washington, D.C., during this particular time period, had the worst black infant mortality rate. And it averaged 16.7 per 1,000 live births. Interestingly, the white infant mortality rate was one of the best. It was 4.3. Yeah? Okay? But let's focus here for now. The best black infant mortality rate is found here in Washington. Woo-hoo. Yes. Yes. It was all for you, Vicki. All for you. Okay? 7.8. Okay? I want you to try to keep these figures in mind. 7.8. This is the best, okay? This is the lowest black infant mortality rate, 7.8 per 1,000 live births. At the high end of the top 10 is Texas, 11.4. Okay? So when we talk about worst, the worst one is here. Kansas, like 15.3 per 1,000 live births. That's during this period. All right. Surprised yet? Okay. I know I was. So then we look at white infant mortality rates. Because this is what I do. I do a comparison because I'm really interested in this gap and why it exists. We look at white infant mortality rates. The best is also, actually the best is here, sorry, is in New Jersey. New Jersey. Anyone want to take a guess what that rate is? Now that you have a sense for what they might be.
6.6.
6? So you said 6.6? 2.6. Okay, 2.6. Anyone else? Anyone else? Yeah. Okay, okay. 3.7. 3.7 per 1,000 live births. Okay? So that's in New Jersey. The worst during this particular year, or this particular average, the worst was Oklahoma, 7.5. Okay. Did you catch something just now? What was that? Somebody tell me what you caught.
It equals the best for
It doesn't even equal it, it surpasses it. It actually, but it's close. The worst white infant mortality rate is better than the best black infant mortality rate. That's one of the issues that really got me involved in this. Because to me, this didn't make any sense. And we'll get to why it didn't make any sense for me. Now, I also, for comparison's sake, I looked at, well, in both states, if we compare both sets of states, what do we get? So up here, this is the worst in both. All right, this is sort of a little bit hard to see. But the worst in both, yeah, you're not going to really be able to see those. But anyway, it doesn't matter. The best in both, Washington, California, Kansas, Oklahoma. Actually, Oklahoma doesn't get in there. Washington and California for sure. New York, and who else we got? Rhode Island, Connecticut. These were some that were the best in both. Whereas when you look at Oklahoma, they tended to be one of the worst in both, as did Kansas, as did Tennessee. So there is some overlap there. There's some things that are certainly happening to both black and white mothers, or some things that could be better. Now, I know what you're thinking. This is kind of depressing, because it is. How about a little good news? Well, there is some, believe it or not. There was a recent New York Times article that said that the US infant mortality rate has actually declined by 12% from the 2005 to 2011 period. And that's excellent news. For years, it seemed to be sort of stuck, but it has declined. And the news actually does get a little bit better. The black infant mortality rate is down 16%. So what do we attribute this to? Well, it seems, based on the CDC report, that there are fewer preterm births. Now, preterm births are the single largest cause or single largest, yeah, I suppose cause is fine, of infant mortality. They account for 2/3 of all infant mortality that we see. So any reduction in preterm births is going to equal a fairly significant reduction in infant mortality. But also, there's this, home visiting programs. Even in the town that I'm in right now, Beloit, Wisconsin, which has, as I mentioned, a high African-American and high white infant mortality rate. We are starting to see home visiting, this idea of nurses and or other trained professionals actually going to your home, to the home of women who are expecting or women who have just had children, okay? Because remember, infant mortality, covers that initial birth period up through the first year of life, okay? And actually going to those homes, visiting with those mothers, helping them to make, in some cases, healthier eating choices and other sorts of options, giving them other options for things that we think about like smoking cessation, alcohol, not consuming alcohol, these sorts of things, and giving them other sorts of support. And it seems to be working, especially in southern states. This is where we have seen the greatest decline in infant mortality rates, because they tended to be the highest, right? And this is certainly the case when it comes to white infant mortality. So now that you have a little bit of a background, I'll tell you why I got interested in this. I'll spend a little bit more time on it. It's because of something that I call a tale of two women. So when I started out trying to figure out what I was going to do for my dissertation, and I knew I was interested in health policy, I knew I wanted to do something about health. At first, I thought, well, let me do cardiovascular disease. I'm from a family, everyone has cardiovascular disease. In this case, everyone has hypertension. And when I say everyone, I mean everyone, right? Myself included, Everyone has hypertension. And everybody got it young. No one knows why they have it. I'm still fascinated by this, but what got me was when I started looking into infant mortality. And I thought, how is it that something like this could still be so obvious? How is it that something as happy as having a baby, which everybody should be able to appreciate, even if you don't like kids, you go through a lot to have a baby, it's your baby, okay? I know people who don't like kids, so it is what it is. But that's at least you can respect the work that it takes to carry something in your stomach for 9 months, okay? Only to have it end in this tragic event, right? You have the baby, you go through all of that, and then in less than a year, the child is dead for some reason or another. And that struck me as sort of profoundly unfair. Like, this is so wrong. It's wrong for everyone, but then it's wrong. It's even more wrong, right? It's wronger, if we can say that, right? It's even more wrong when we look at this long-standing disparity. This didn't pop out of nowhere. This has been something that we've known in public health for decades. And I'm not talking 3 or 4. I'm talking like 10. Okay? We've known it going back 100 years that there was a gap. So what I started to do initially was I had this idea that maybe what's going on is that there is this life course difference between black women and white women. That's all there is to it. There's just, most black women they come from families that are poor, and most white women don't, right? That's not actually true, okay? But there are some substantial differences. So how did I try to get at this? Well, one of the things I did was I said, well, let's try to control for the educational component by looking at these intake surveys. These, they used to say freshmen, but first-year intake surveys, right? Some schools did these, and I happened to find only a couple of them online. And the couple that I saw, they sort of corroborated what I was thinking. When you looked at the black women who were filling it out, where did you come from? There's always a question. Where did you come from? Did you come from a rural setting? Did you come from an urban setting or a suburban setting? overwhelmingly, the black women came from urban settings. Overwhelmingly, the white women came from suburban or rural settings. So, okay, maybe I'm onto something here. But, you know, funny enough, though, when you looked at socioeconomics, those didn't tend to be too different. Of course, when you generally look at it, the white women tended to come from homes that had higher income and parents who had gone to college. Of course, we saw a number of the black women coming from homes where they were the first to go to college, right? But this is sort of consistent with what we already knew. But I wasn't able to find more data. So I had to put that aside for a bit. And I decided, well, I'm being trained as a political scientist, maybe I should look at some sort of policy. And given that I was also focusing on race and ethnicity, that's one of my subfields, I said, okay, what about those amazing policies we had not that long ago that were spread out across the nation called anti-miscegenation laws? Is everyone familiar with those laws? Do you know what I'm talking about? I see a couple people shaking your head no. I'm both happy that you don't, and at the same time a little sad, because it tells us that this is a history that we have not fully encompassed. We haven't fully understood it. Anti-miscegenation laws are those laws that existed in the majority of states. I'm going to say it again. In the majority of states that prohibited marriage between whites and non-whites, typically blacks. Okay? But by the end of it, most of the laws prohibited marriage of any kind between whites and non-whites, and occasionally even between different minority groups. Okay? So I thought about those, and I said, well, let me take a look at those. But at the end of the day, I came away not very satisfied. Yeah, I found some policy effects. You know, and I'm sort of skipping ahead, but I found some policy effects. In particular, I found that states that had really intensive anti-miscegenation laws, ones that were just, you know, not only can you not marry, but if you are found to marry, you get 10 years in jail and all of this sort of stuff, right? I found that those states did indeed impact policy, right? So those states, when they looked at welfare policy, their welfare policy tended to be stingier. They tended to spend a little less money. But I was never able to tease out if that was just because they also tend to be poorer states, right? I also found an interesting effect for white infant mortality rates, because it turned out that white infant mortality rates actually did vary the way that I predicted black infant mortality rates would. So the states that were the most intensively racist in this respect, white infant mortality rates tended to be higher in those states today, but not black infant mortality rates. So one of the questions is sort of what's going on? I mean, what is really happening? Well, one of the things that we see with black infant mortality, as I've sort of intimated already, is that low birth weight tends to be a problem. Right? Low birth weight, meaning less than 2,500 grams at birth, that's less than about 5.8 pounds. No, 5.5 pounds. And low birth weight tends to be nearly double for infants born to black mothers. And as you might imagine, low birth weight is associated with preterm birth, which again, black mothers, they're at a 60% greater risk, right? Nearly 1 in 5 black mothers can expect to have this happen. This is very strange. And so I continued to think about this. I said, well, yes, but why is this really happening? Well, I'm guessing that it's the impact of racism, and a lot of the literature backs this up, right? We talk a lot about, think Robert Hummer, David and Collins, David Williams, and Chiquita Williams. They all talk about the impact of racism on health, right? And I'm definitely one of those folks. But I was looking specifically at this idea of maternal stress and maternal weathering. I thought, maybe this is something. Because even at this point, I'm thinking there's something about the personal history of these people. So that question that I asked you at the very beginning, where's the history? I thought there's something about their personal history that is going on here. At that point, I guess to a certain extent, I was already thinking about social history as well and how that might be shaping policy, but I'll get to that in a minute. But when I came across this, I thought that this made a lot of sense to me based on the numbers that we were seeing. But I'm going to come back to this. So to say a little bit more about what I found and what I was attempting, I thought, well, maybe it's the policies of the past, right? That's what the whole thing was about these anti-miscegenation laws. And so I came up with this spiffy little design. I said, oh, okay, you know, from the US Constitution onward, we have all of these policies that sort of reinforce a racial hierarchy in the United States. And that maybe this is creating this inertia that's determining policies going forward. It's creating what I was calling a racialized political culture that effectively only legally ended in 1967, but still has this sort of legacy effect that's moving forward through time. And I don't doubt that is happening. But, like I said, it wasn't a satisfying enough explanation for me, right? So did it have an impact? As I've already explained, sort of. Just not for black infant mortality. So, of course, at this point, you're thinking, well, Ron, you're missing all of the big stuff. It's the social determinants of health, stupid, right? Don't call me stupid. I can call me stupid. But that's probably what you're thinking. You're missing all the big stuff. I mean, all of the, you know, the big money really, especially today. And I'm happy about this, okay? I don't want you to think I'm not happy about this. The social determinants of health, yes, they're very important, extremely important. Now, pop quiz 2. Poverty. You think that has a big impact? Yes? No? Think I have I mean, now, of course, you're like, oh, I know if I say yes, he's going to say no. All right. How about education? Surely education must make things better, right? This is one of the things we all learn, correct? What's part of socioeconomic status? It's income, it's education, right? It's things like where you live, right? Surely that must matter. Well, how about behaviors? Well, if you smoke cigarettes during your childbirth, you can expect a child to be born preterm or low birth weight. Everyone knows that, right? Maybe what's happening is that these mothers are smoking more, or they're in situations where there's more tobacco and tobacco use. Maybe what's happening is they're just not going to get the prenatal care they need. Everyone at this point in history knows you need to go get prenatal care. Maybe that's what's happening. Or maybe it's because so many of the mothers are unmarried and they're teen mothers. Maybe that's what's going on. It's all of these behaviors. So, given that I've already led you on the earlier questions, you already know the answer, right? Nope. Nope. Still nope. Okay, what we have effectively found is that when it comes to income, and I'm going to show you some data here in a minute from Wisconsin, but the data is actually consistent with the United States as a whole. When it comes to income, if anything, what we find is that black mothers who have higher income, there tends to be a widening of the gap. Okay, they do experience a small, very small decrease in infant mortality rates for that group. But it's a very, very small improvement that they get. And the gap between them and their white cohorts actually increases over when they had less money. Okay? We see the same thing for teen parenthood. Okay? For teen mothers. When you're a black teen and you give birth, infant mortality rate generally, depending on the year, is around 14, 15 per 1,000 live births. You wait a little bit, wait till you graduate from college. Depending on the year, it can actually go up. That's right, it can actually go up. Okay? But sometimes it goes down a little bit. You know, maybe two percentage points. So from 15 to 13. When we look at white women, though, if you have a baby when you're a teen, those women see infant mortality rates of about 9. Okay? 9 per 1,000 live births. You wait till you're about 24, 25, goes down to about 5. Wait till you're 30, goes down to 4, like 4.9 or something like that, into the 4 category. It's pretty amazing stuff. Behaviors. What we consistently found, and what we have consistently found, is that if anything, black mothers smoke less, they drink less, and especially among those who are socioeconomically disadvantaged, they seek out prenatal care faster than their white cohorts. And it seems to have very little effect. And I'm going to show you something here. Like I said, this is from the state of Wisconsin. If you can see this. And I apologize for it not being as big, but I want to try to keep everything on screen. So when we look here, as I mentioned before, 20 to 29, 12.8. Okay, we see a drop here, 5.2. But look at this, 30 to 39, 15.6 versus 4.6. Okay? These are the kind of numbers that we're talking about. All right, as a teen mother, on some level I think all of us go, well, we sort of understand what might be happening. We don't have enough resources. Yeah, okay, sure. How are we explaining this? And then look at this. 23.4. 23.4. Then come down to education. Well, yeah, education will save us. Surely education will save us. Well, I want you to pay close attention to something here. This is white women this is the infant mortality rate for white mothers who have less than a high school education. Look at this. This is African American mothers with more than high school education. That means some college or more. 13.6, 9.6. So that education boost, well, it is there, okay? But at no point does that infant mortality rate fall below that of the least educated white mothers. Marital status. Well, there's so many single mothers. Of course, there's resource scarcity and all these problems. Yes, you're absolutely right. Except look at the improvement. That is statistically negligible. Negligible. All right. Thanks for depressing us, Ron. Surely cigarette smoke. No, that's not over yet. Okay? Because yes, you do see an improvement. Smoking while pregnant, bad idea. Okay? As I'm the public health person telling you this, don't do it. Okay? It's a bad idea. But if you compare these improvements, right? If you look at it a pure percentage point improvement, yes, there's a greater improvement here, about 5 points versus under 4. But when we look at the sheer rate, not smoking at all, again, they didn't smoke compared to white mothers who did. So these are the sorts of data that really confounded me in trying to look at this problem and trying to unpack it and understand what's happening. Let's get our PowerPoint back up again. So, this all brought me to some things that I had heard before. I mentioned maternal weathering, so I wanted to put that in your ear because I started to come back to that. I said the policy piece wasn't really, it didn't have the impact that I was looking for. And I remembered maternal weathering, and I also remembered something more importantly. What I heard Nancy Krieger, or rather what I wrote, what I saw that she wrote before. So Nancy Krieger is this big name in public health. Most of you know who she is. And she had written something once to the effect of, we all carry our histories around with us in our bodies. And that really grabbed me, particularly because of the cardiovascular thing that I was saying before, right? My life is stressful, but it's no more stressful than anyone else's. At least that's what I sort of thought. But I thought, if we're carrying histories around in our bodies, given the history that this country has, the unrequited history that it has around race and race relations, that maybe, just maybe, that's where the action is. Maybe something has gotten in to people, that's gotten under the skin, as we often talk about stress getting under people's skin. Or maybe something has gotten really deeply under the skin of Black American people, and in this case, Black mothers in particular. And so it drew me back to this idea that Nancy Krieger was talking about, called embodiment. And so, just to give a little bit of the definition, so embodiment refers to how we, like any living organism, literally incorporate biologically the world in which we live, including our societal and ecological circumstances. Now, this was not a big stretch for me, given what I already knew about the clear racial disparities and racial differentials in income, education, in neighborhoods, right? Residential segregation is real and it exists. So I thought, all right, maybe this is it. So as I continued to think about it, I came to understand embodiment as being this sort of multi-stage framework for potentially understanding how we can have multiple points of causation that can get us to many of the health disparities or health inequities and inequalities that we see. I became convinced of this, and I still am, and we can debate it. So I effectively see embodiment in three more or less distinct stages. I call one of them, using Krieger's language, proximal. And she uses these words, proximal and distal. Proximal embodiment. Well, what's that? Well, proximal embodiment is the physical incorporation of conditions over a recent time span and that impact an individual's current health. That's how I'm defining it. Okay? So you can imagine a car accident, right? That's a very acute situation, right? But that's a proximal embodiment. You are embodying this event that occurred, right? You can even think of it in terms of things like living next to, you moved in next to a nuclear reactor, right? And the nuclear reactor had an accident. Or you lived in a community that had an incinerator, right? You moved into it. And there's really no controversy there, right? I mean, we can all understand how that impacts your health and how you are embodying that event. And then there was this one, this idea of life course embodiment. And there's been a lot of conversation around the life course, and I've been glad to see it because I think it's important for us to understand that events that happen to people when they're children can have later impacts. And there have been a few studies I'll mention in a second. But life course embodiment, the way that I see it, is the physical incorporation of stressors over an individual's life course, right? From the time you're born up until time in, okay? That accumulate to result in health disadvantage. These stressors accumulate in your life. So you didn't just move in next to an incinerator. You lived there from the time you were born, right? You lived there. You lived in a situation in a neighborhood that was filled with violence, okay? There have been a number of studies that show that folks who live in neighborhoods that are run down, where there's violence, believe it or not, they tend to have higher blood pressures. Right? I think I would too. And then there's the last one. And this is probably a bit more controversial, but this is sort of where I am when I think about this issue of Black infant mortality and trying to get a hand on it. And it's what I'm calling transgenerational embodiment. Right? And I didn't come up with this word. A number of folks who use it, Kuzawa and Sweet use it as well. But I call this transgenerational embodiment. I say it's epigenetic changes, and we'll talk about what that means for those who don't know, due to immediate or life course embodiment that impact the health outcomes of future individuals. Okay? So it's not just you. The whole part and meaning of it being transgenerational is that now those who come after you are going to be impacted by what impacted you. So another way to think of this is that it sets the stage for what one might call an extraordinary sensitivity or predisposition to things, right? So that's what, when we talk about epigenetics, for those who aren't familiar, epigenetics is this idea that our interaction with the environment doesn't cause genetic change, but it turns on or off certain genes, right? And that turning on or turning off can continue to a few different generations. And there have been some studies, we'll get to it, I'll mention those again at the end, that suggest that this may be happening, particularly around the experience of famine. So yes, we've talked about embodiment. And if you accept that embodiment is something that's actually happening, then the question becomes, well, what do we do? And you have to understand, for me, embodiment is important because it unequivocally recognizes that the lives we lead, the histories that we experience, that they actually matter. Your personal history and our social history, these things matter to how your health is. But I also love embodiment because it talks about something else. That if you are embodying historical events that you were not even part of, what does that say about social justice? To me, it gives a whole new call for social justice. Because people are basically effectively being held accountable in their health for things that they had no part of. Right? I've heard that conversation I've had that conversation with people on the other side of the question. Right? And we can talk about that later. But anyway, what do we do? Well, how do we identify? I think there are three important questions, at least for me, that trying to think about what to do if embodiment is something we accept, and if you accept my definition of it as this sort of three-stage system. What do we do? Well, how do we identify instances of embodiment? Well, this is easy in the United States, unfortunately, because we have enough data at this point to show us where certain types of events and certain types of health outcomes that we suspect embodiment might be in play, especially the transgenerational part, where that might be in play, are. So, for example, infant mortality, right? For certain other communities, diabetes. For other communities, cardiovascular disease, violence. All of these different things that we consider to be public health emergencies, yes. I think that we already know where the embodiment may be happening. The issue is then identifying what stage of embodiment we might be talking about. Another question, how do we measure it? Okay, so how do we go about measuring it? Well, for me, I think you measure it in a number of ways, and I'm going to read from my notes here. One way is that we take an inventory of the current living and working conditions of the people we suspect the individuals or communities we suspect where embodiment may be happening. I also think something that we already do is personal and family history. When you go to the doctor tends to ask you, you always fill out that form, tell you about your family history. I just think we need to take that a lot more seriously. A lot more seriously, particularly when we're talking about infant mortality, because we know where the problem is. Also, we need to do a lot better job of measuring the physiological markers that could tell us something about embodiment. There is some work happening today in which researchers are trying to measure cortisol levels in the blood. Some of you know about this, right? Cortisol is an adrenal hormone that tends to be associated with what? Stress, right? It works out really well when there's an actual stressful event happening. You know, if a pit bull starts chasing you, adrenal hormones go and you're like, or, you know, you lay down on the ground and let the pit bull eat you. But generally speaking, you run, right? And so that's great. The adrenal hormones help to focus you. They make you hyper vigilant, hyper aware. And that's all fine and good unless it doesn't end. When it doesn't end, when something continues to keep your stress level high, that cortisol that's in your bloodstream begins to have an effect, a damaging effect on your cells. Oh, before I go there, I should say also, we cannot forget the psychological measures that are necessary here. Perceptions of discrimination, perceptions of mistreatment. These are also important. So another way to measure this may be to ask questions about a person's life and have that be meaningful. What's going on in your life? What sort of life events are you having that could be elevating your stress level? You know, when you talk to people who are in these amazingly stressful circumstances. I just watched this film, Escape Fire, the other day. And there was a woman in there. And she came in to the office. And she was talking to the doctor. And what the woman had to say stressed me out as a person watching it. The doctor said, well, you look like you're really upset. And she was like, well, yeah, I am upset. My son is over in Iraq. And then I just had to switch jobs. Oh, no, she lost her job. And I just lost my job. And then I just got kicked out of my boyfriend's house. This one person was having all of this stuff happening at once, right? I mean, these are some stressful life events. And many of you probably know folks that are always coping with some sort of event like that, like real events. You know, somebody got shot. Somebody had to make bail, right? This kind of stuff. Somebody just found out they had diabetes and had to get something amputated, right? But I think most importantly, what we want to know is how do we prevent its effects? I have my own ideas about how we can do that. But what I really want is to talk to you about this. So this is one of the questions I want us to come back to. Now, maybe at this point you're thinking, okay, embodiment, yeah, all right. I get it on the first two. They make sense, life course. You know, proximal things, very car accident, okay, you're embodying a physical trauma, got it. The transgenerational thing, I'm not really buying that so much. Okay. And your rationale may be correct there. Maybe it's just the stress of racism when we're talking about black infant mortality rates, when we're talking about why that gap doesn't close, no matter how wealthy or how educated a black mother is. Maybe that's what's going on. Maybe it's just so prevalent that we don't have a good sense, because only recently have we even tried to measure what the physiological impact of constantly experiencing microaggression. Constantly, everywhere you go, there's a sort of denial of who you are. Constantly, everywhere you go, there's a sort of threat. That until very recently, we haven't even bothered to try to measure that. So maybe that's all that's happening. Maybe it's just that racism in our society is so prevalent, and that African-American people, just because they're hyper-vigilant about racism, that this is what's happening. They're just stressed all the time because of it. Maybe that's enough. Maybe there's nothing transgenerational happening. Okay. In other words, it's stereotype threat to the nth degree, right? This idea that you walk into a situation and the fear of confirming someone's stereotype is enough to cause your blood pressure to rise, is enough to cause you to act and behave in a strange way. Generally, we think of stereotype threat in an academic setting, right? When it comes to academic performance. And in that context, stereotype threat can affect everyone. Specifically, though, women and non-white people. But when you consider all of the different life chance and sort of life danger things that could be connected, especially for African-American folks, especially for African-American males and females, especially those living in inner cities, maybe it's just this. Maybe that's all that's going on. But I would submit to you that there are a number of studies, and I wish there were more, but they are coming forward, suggest otherwise. They, at the very least, and these are studies that looked at non-black people, right? They weren't looking at black mothers. There's one study that was done in India that looked at paternal and maternal birth weight. And they were trying to determine, does that impact or otherwise give us any indication about what the baby's birth weight will be. And so there are a couple of other studies that show that maternal birth weight has an impact. There are a couple that show that it doesn't really. And in this study, they looked at both. And what they found was, well, there wasn't really a super impact on birth weight. But what we did see is an impact on later chronic disease susceptibility. All right? So, okay, birth weight tended to be normalish, but those folks tended, by the time they got to their 30s, 40s, tended to be folks who were starting to have some sort of metabolic syndrome, some sort of metabolic disease. They tended to be pre-diabetic and this sort of thing, right? There was another study that looked at the Dutch famine, the people who had survived that, and looked at a generation of women who survived it, and looked at the generation of female offspring afterwards, and they found a similar sort of connection. So there is some evidence that there are transgenerational elements of embodied, internalized traumatic events. There's some evidence of it. I don't know much, but I do know this. And I'm thankful to David and Collins here for really doing this work. Is that when we look at first generation African immigrants, this is birth weight. We see that they're the dashed line here. We see that their birth weights tend to be almost identical to US white birth weight. Then we look at the second and third generation. You see the direction? You see where we're going? And then we're all the way over here with African American birth weight. So anyone who has the idea that it's just genetic, right? There's something about being from Africa that does this. Well, I love it. I'm glad you're laughing because that is stupid. And I used it. I said it. I used the word stupid. It is stupid. It's asinine. And it's asinine because it not only neglects the entire history of what happens to people in the United States, but it also assumes a very genetic deterministic view of how people are and how their health is, right? I mean, for one thing, it makes the assumption that there's been no admixture at all with people who came from Africa centuries ago. And we know that that's ridiculous, okay? So the one thing I do know is that it's not genetic. The one thing that I'm very, very suggestive of is that there's something that happens when people get to these shores that turns these people into these people. That's the one thing I know. Kazawa and Sweet, I love this because they saved me the trouble of trying to figure out how in the world you put together this sort of diagram, but they did it. They are looking at transgenerational embodiment in this way. They're saying there's this prenatal stress. It induces changes in metabolism and physiology. Then you become an adult. And in the adult world, you've got ongoing stress. Then that stress, the maternal body is experiencing that stress. She has higher cortisol levels. That cortisol, because it's so high all the time, it starts to pass through into the amniotic fluid, into the sac. It's going in, and it's impacting the infants that are in the womb. They're in turn becoming even more susceptible, in this case, to stress and other sorts of inputs. They become adults, ongoing stress, and so it goes. Now, how do we disrupt this? That's one of the open questions, and that's the question I want us to return to. But one thing that we have to do is we have to unravel the mechanism behind embodiment. We've got to do that. We've got to figure out what's going on that is causing this difference, what is happening in the lives of our citizens that is resulting in an event that should be happy, that should be something that, I mean, I'm one of those people. I believe every baby should be a wanted baby and all of that, okay? But it's causing this event that is costly in more ways than one, right? I haven't even talked about it. Hopefully we'll get to it in the questions. I haven't even talked about what the financial costs are of these losses. But what I'm hoping is that we can unravel the mechanisms of embodiment, but also that in doing so, we'll come back to a conversation on social justice. This conversation that I mentioned before. Why is it that some people experience life this way? Why is it that certain people tend to be paying the price for events that they didn't cause either? And I think that within the concept of embodiment, sort of embedded within it, is a call to action. That if you do believe in a just society, that you have to ask, then why is our society not just? And why have we not taken steps to ensure that it is? Well, that is all I have for you today. Thank you. And let's move to some questions.
So the way that we structure these speaker series is after the speaker finishes up, if you haven't been to an RWJF talk, we have two what we call initial brief discussants that essentially pose thought questions that they've thought a bit about in advance for the speaker, in this case, Dr. Nikora. After he addresses those, then we open it up for larger Q&A. So the way that we've structured this one is by having one of our RWJF fellows pose the first question. If you have not had a chance to think about the structure of this, the beautiful thing is embodiment, which Dr. Nikora has done a great job of providing a great overview of, is essentially what the fellows at our center have been engaging in terms of the literature, the research, how to measure this dynamic over the course of the academic year. So Alma Hernandez, who's from the Department of Sociology, a PhD student, one of our WJF fellows, is going to kick things off by starting the question and answer session from the perspective of the fellows to Dr. Nikora.
Okay, thank you. Are you going to come stand next to me as well? Okay,
Yeah.
go ahead.
Yes. Okay, so as you know, we have been discussing relevant research pertaining to maternal health. So given what we know about maternal health, we wanted to ask you, would you please comment on using mixed methods to look at the effects of lived experience to deepen our understanding of these disparities that you talked about?
That's a terrific question. Okay, so the idea, everyone's familiar with mixed methods, right? The idea of using, quantitative, qualitative, and any other types of techniques to try to get at this. I think with embodiment, you have to take this in a mixed methods approach, because part of what I mentioned is that people's stories matter. And that's one of the things that Krieger also says about the idea of embodiment, is that people's bodies are telling stories. And they're oftentimes telling stories that are hidden, or that the people themselves don't know or can't articulate in some way. So how do we get at that? Well, look, the stuff that I've done has been largely, looking at quantitative data, right? Crunching numbers around state infant mortality rates. But one of the things that I've been fortunate enough to experience is I'm part of a group in Beloit, Wisconsin called the Beloit Life Course Initiative for Healthy Families. And their focus specifically is reducing the town's extraordinarily high black infant mortality rate. It's like 16 per 1,000 live births, and there aren't 1,000 live births. I mean, it's pretty shocking. But one of the things that you learn when you sit in those meetings and you talk to people, especially people who almost lost their infant, they had a preterm baby, and you talk to them, you realize there was so much going on for them, both in terms of the concern and the worry about their infant, but also things that they themselves didn't recognize was happening. One of the women, she was married, going back to our data, she was married, was a career woman. She must have been 34 or something, right? You think that's a good age to have the second baby. Her first baby went fine, no real problems. And it was when she had her second child, or when she was trying to have her second child, where she started experiencing these problems. She said, what's going on here? And no one told her that, you know, because you're a black woman and you're 34 now, I mean, the chance of you losing this baby at some point, either because it's preterm and it comes out and we're able to keep it in an incubator, but the baby ends up dying, or just, you know, because the baby's going to have low birth weight and there are going to be complications associated. No one told her that. So she was having these labor pains, and she just thought it was just, you know, like gas or something. She didn't know. And so that's part of, I mean, it's a bit convoluted, but that's part of why I think mixed methods is important. Of course, we have to look at the aggregate data around these things, I mean, particularly around infant mortality or any of these other health inequities. But we also have to listen to people's stories and try to hear, because the thing that got me about it is she told her doctor that. And her doctor was like, oh, you're fine. You know, you're probably fine. Just go back home. Because the doctor didn't know. The doctor didn't realize, right? They're not attenuated to it. And that, knowing that story, that also to me is a part of this whole puzzle about how interactions with the healthcare system are also one of the factors that we have to consider. And you can only learn that from talking to people. You can't learn that from looking at just the quantitative data. Okay?
So our next and final, before we open it up for larger Q&A, from a faculty member affiliated with the center, Dr. Nancy Lopez, Associate Professor in the Sociology Department, our recruitment coordinator at the Robert Wood Johnson Foundation Center, but also is the director of a sub-center for race and social justice. So Dr. Lopez, take it away with the next
Awesome.
question.
All right,
I
Nancy.
really loved your
And
presentation.
then Ron, you
Thank
can
you.
handle Q&A.
Yeah, sure. Thank you.
Just a
So-
quick note for the camera in the back, the only mics are on the camera and up front next to Ron. So Ron, you may have to paraphrase the question into the mic. So
That's fine.
Okay,
Okay.
great. So I was thrilled to see this presentation because it speaks very much about the need for analytical clarity about race, and it also speaks to the need about analytical clarity about ethnicity. And one of the things that came out of the Institute for the Study of Race and Social Justice, that's housed at the center, is an NIH-funded volume called Mapping Race: Critical Approaches to Health Disparities Research. And in there I actually include a chapter that speaks very much to your work, and I'm thrilled that I'm learning about it. It's called Contextualizing Lived Race Gender and the Racialized Gendered Social Determinants of Health. And I talk about my own experience as a US-born Dominican woman, daughter of Dominican immigrants, who experienced what it's like to be pregnant while black in the United States, and all the microaggressions that come along with that. So one of the questions I have for you is about the data collection that happens at the national level. So in Hispanic communities, of course, one of the birthplaces of slavery, you know, the Dominican Republic and the Caribbean and the rest of Latin America, it is interesting to find out how Latino blacks are counted, if at all, in the national data. Currently, it's probably up to the discretion of every state. So one of the things I wanted to know is whether or not there is a way to account for blacks that may not officially be counted as blacks in looking at infant mortality rates, but also to get us to think more carefully about race as a multidimensional phenomena, that it's not only enough to collect data, asking people how do they identify, but also capturing exactly what Dr. Nikora was talking about, things like lived race gender, right? Microaggressions, experiences with racial discrimination, and capturing how other people see you, because you do have the phenomena of many Afro-Latinos not identifying that way, but actually being classified as black as they go access healthcare or as they go about their daily business. So if you could shed some light on that.
Okay, I'm going to try to mention a couple things. This idea of how are we actually measuring or capturing black Latinos? This is something that vexes me as well. I talked to a few people about this, and the best consensus that I get is that it's being left basically to the census. What am I saying? It's being left to the census for the highest level quantitative data that we have. But then when it comes to actual infant mortality, we generally speaking only see it broken down by black, white, and occasionally nowadays Hispanic, and that's all about self-report. So, I mean, my assumption because of that is that is that people who are identifying as Hispanic are capturing even Black Latinos. That's the assumption that I'm making. But, of course, the lived experience of being Black Latino is completely different than the lived experience of being non-Black Latino. Because on top of all of the other aspects of being Latino that also sort of engender and trigger certain types of discrimination and behavior of others towards one, on top of that, they have to contend with being viewed as African American. And in other words, there's this sort of additional aggression, microaggression we call it, right? In which you're being deculturalized, completely deculturalized. And we know that culture is important to people. We know this. So, you know, so that's what I can say on that. I wish I had more information myself on it, but this is one of those areas where it remains a little bit gray. Now, you had a second part to your question as well.
It was about the analytical distinction between race and ethnicity and looking at generational status even.
Yeah.
That slide that showed the ways in which African immigrant women experience the same birth rates with time, right? African immigrant women speaks to the idea that this is something about how they're racialized in the United States.
Yeah.
And currently we have no way of capturing generational status in any of these data.
And not effectively. I mean, not effectively at all. I mean, that's one of the brilliant sort of innovations here that David and Colin sort of brought to this, is that they had the great fortune of having these data, right? But, you know, part of this intergenerational thing, too, is that as it turns out, every immigrant, no matter what racial or ethnic group you identify with or that you are being sort of identified with, experiences a decrease in their health status when they come to the United States. Everyone does. If you're, you know, a white Frenchman and you come to the United States and you stay 1 generation, 2 generations, 3 generations, your children are going to see their health status decline. Of course, the decline is not as significant as we see with African diaspora populations. It's not as significant. But there's a transgenerational effect. This is why I completely buy this, because there's something happening in the United States to everyone. It's just happening to an even greater degree to people of African descent. Okay? So that's what I hope that sort of touched on it enough. Any other questions? I mean, I left a lot unsaid because I was hoping to trigger some debate, but I also mentioned something about cost. Any conversations about that? I mean, the cost of infant mortality. Okay, well, I'll just say it. It's high. Okay, so why is it high? Right? There's a societal cost. You can see it in terms of an economic cost, but you can also see it in terms of a social cost, right? Today, more than 40%, that's right, 40, more than 40% of all births are paid for in some way or form by Medicaid. Did you know that? Well, some of you did. I know Vicki knows it, right? But more than 40%. So think about this. We have 40% of all births being accounted for by Medicaid, which is, you know, that's tax dollars no matter how you slice it. Then you have preterm births in the United States, higher than in any other developed country. Okay? Preterm births associated with the use of newborn intensive care units. Now, I don't know if you all know this or not, but just like if you go into a regular intensive care unit, you know, the price tag for your hospital stay just did that. Right? I like that move. My kids do that kind of stuff all the time. But it just went sky high. And it's the same thing for infants. Now imagine the social cost. You had someone, they delivered a baby, the baby was preterm, it had to go to the NICU, and then the baby still died. At the end of the day, what has society gained from that? I mean, just look at it in a rough way. Forget the social justice stuff and the baby is beautiful, you can't put a price on life. Forget that for a second. What was society's net gain from that? There was no net gain. Because part of having children in a society is that you continue to the children grow up, they become productive members of the society, they then sort of pay taxes and they end up, this is how societies keep running. This is how it goes. And society not only did those parents not gain the happiness of having the child that they wanted to have, or having the child and having the child die before it turned 1 year old. Not only did their states, and then to a lesser extent, the federal government, end up, and then to a greater extent, all of us as taxpayers, end up paying for this expensive intervention, very, very expensive intervention. But then we ultimately, down the road, what we were looking for doesn't come back to us. In that sense, it's extraordinarily, extraordinarily expensive. Now, one of the things that I'm trying to do with some folks in Beloit is trying to see if there are ways that we can disrupt that preterm birth, low birth weight cycle through the use of doulas. Do people know what I'm talking about? Okay, these pregnancy helpers. We consistently find that doulas and midwives, when they are present, mothers report much higher satisfaction with their births and their birth outcomes. More recently, and to me more importantly, what we found is that there was a study that was done, came out just this past year, that showed that if doulas were present during a delivery, during the sort of crucial phase of the pregnancy, that doula's presence was associated with a nearly 40% decrease in the rate of cesarean sections. When I read that, I actually had to read it like twice, right? A 40% decrease. Because remember, vaginal birth, that's the cheap one, okay? I know, this is how I am. My students hate me. But this is how I talk all the time, right? I mean, that's the cheap one. The one that's really expensive, and then, of course, outside the NICU, the very expensive one, is having to have a cesarean section, right? And they have been on the rise in the United States since the 90s for a variety of reasons that we can talk about. But when you put all those factors together, what we reason is when you put all those together, including also like home visits and that sort of activity, we may be able to disrupt this cycle somehow of preterm birth. At least that's what we're hoping, right? And if we can do that, we save the state of Wisconsin money, right? And if that happens, maybe this is something that catches on nationwide, right? That this is this cheap intervention, you know, just paying people a little bit of money during this particular period that could get us better outcomes. And guess what? People get to have a relationship with each other instead of pursuing a pharmaceutical solution to this. So I talked more. I told you I love to talk. Please ask questions, anything. You know, why'd you wear that shirt today? I mean, you know, I'm open to anything. I'm not shy. Yes, Shannon.
I'm really intrigued by your idea of thinking about how to collect lived experiences, and it sounds like in a very qualitative way.
Mm-hmm.
And I'm wondering, I think you're right in stating that people aren't always aware of what they're carrying, but it comes out in narratives.
Right, yeah.
How do you want to collect and analyze that? Because that's tricky, right? Because there's people who would say that, you know, using some sort of this interpretive framework you might be reading into things that people aren't really saying. How are you thinking about operationalizing that?
Yeah, I mean, you know, this is so Shannon's question is given the sorts of measures that I'm talking about in trying to get at this idea of what's happening with people's personal lives that could be leading to embodiment of stress and trauma. It sounds very, there's a sort of interpretive element to it. It's very qualitative. Yeah, you know, which is fine, of course, right? But how do you deal with that and deal with maybe the criticisms, right? That, you know, this is maybe too interpretive. You know, Shannon, that's a great question. I sort of have resolved to view it in a sort of quasi-quantitative way. Because my guess is that when we start to collect the data, that we'll start to see patterns, right? I don't assume that every single person is going to tell us something completely different, because the experience, especially when we're talking about various population groups, the experiences are unfortunately too common, right? I mean, that's the rub of it all. You know, if you happen to walk in and you happen to look a certain way, people are going to judge you, you know, 8 times out of 10, depending on that person, the same way as they would judge someone else, completely different personality, but judge you the same way as them. And so if they're experiencing when a black woman, Nancy can say this too, she's a Latina, but she walked into the place and she probably got treated the same way that this woman in Beloit got treated, right? And so I think that as we collect the data, we'll start to see the patterns. But I think the initial step is in collecting it, is in understanding that it's actually important to collect. And that's something that I'm very much in support of, at least letting people tell their stories when they can. Yes, Irma.
I wanted, speaking of the fact that you just mentioned Latinos, I wanted to ask you about doing instead of doing a black-white comparison, including a minority group such as Latinos to sort of look at those differences. Do you think that it would help paint this picture of disparity?
You know what's interesting, in the case of infant mortality, not as much. In the town that I'm in, we do see sort of in a, this is rare. We see a slightly elevated infant mortality rate among Hispanics than we normally do when we look at the national data in aggregate. You've all heard about this Latino paradox or Hispanic paradox. And that's part of what I'm getting at there, is that generally speaking, when it comes to infant mortality, if anything, Latinos do better. They do about the same, or on occasion, depending on the year, because of course there's fluctuation by year, better than whites. And Asians, some of you know I'm married to a Japanese woman, right? And of course Japan has one of the lowest infant mortality rates in the world. In fact, the second lowest, I think. Monaco has the lowest, according to the CIA. CIA, World Fact Book. I don't work for the CIA. The World Fact Book. But yeah, I mean, but she's sort of emblematic of why we don't include Asians in the study either. They do a lot better than everyone else, right? A lot better, And so bringing in other groups for infant mortality outside of American Indians, okay? That's the group that I actually want to start focusing on next. And I'm going to need partners for that, which makes it sort of fortuitous that I lived in New Mexico for so long. Because New Mexico really does attenuate you to the fact that our indigenous people are here and they are alive and they are suffering just as well. When you go outside of New Mexico, you don't get that so much. And that's really bad. But that's the other group that I'm hoping to bring in. But yeah, when it comes to other health problems, oh yeah. If I was looking at cardiovascular disease, if I was looking at diabetes, I mean, that's where you start to see the gradient across the racial and ethnic groups. Again, with putting Asian Americans aside for a second. So for sure. Anyone else have something? Shannon, okay, Shannon and Nancy. So Nancy, let me let you go and then we'll get back to Shannon.
So one of the things that I guess I'm struggling with is the epigenetic argument.
Yeah.
I understand all of the other arguments about I'm having these microaggressions right now or over my life course, but the epigenetic argument in a way kind of resuscitates for me some of the essentialist discourses on race.
Yeah.
And so I don't know how many of you are aware, there's a study that was done with Arab named women post 9/11 indicating that their birth weights were pretty normal, but post 9/11, right, something happened, microaggressions, right? These women suffered the same kinds of stigma that black African American or women of African ancestry are subjected to. So that would speak more to what I'm calling the racialized gendered social determinants of health, and in this case birth weights, rather than the epigenetic. This is something that's embodied and carried and translated, and we can measure it at that level. So I don't know how you grapple with that.
Yeah, I mean, that's really an important issue. And part of it for me too, because I grew up in the era where we saw the publication of the bell curve, right? I mean, you talk about genetic essentialism at its worst, right? Oh, blacks and Hispanics and everyone else, they just have lower IQs. So we shouldn't let them into college. Never mind the fact that there is no such thing as a racial intelligence project that requires all whites are in on this project or all blacks are in on this project. It doesn't exist. But this is racial essentialism. And it is my fear a little bit that that when you bring up the epigenetic argument, people say, well, we didn't have the right language. But see, we told you. There's something about you guys that's weird. But that's also, so this is part of my sort of weird love-hate relationship with epigenetics. In that, yeah, it's possible you could go there. But what epigenetics tells you, more than anything else, is that these perceived sort of genetic changes are actually things that were triggered, that were caused by some event. They were caused by the interaction of with some environment or some trauma of some sort. They became internalized. And that's how I ultimately justify it. I say, well, look, what it's really telling us is that something happened to our ancestors. Like something happened to them. Not that they were just born one day and was like, oh yeah, this is wonderful. And it just turns out I happen to have low birth weight infants. That no, something was done to them. And that's why this is important. There's some process that happens to them, and it continues, and it continues. But it also is hopeful for me, because it also implies that that condition can be changed. And that's where it really parts company with genetic arguments. Because genetics, once you're in, you're in, right? But with epigenetics, it means that if efforts are taken to understand the event that happened, the mechanism that allowed that event to be perpetuated from one generation to the next, if we understand it, then we can take steps to correct it. And that's what makes me hopeful about it. I still think that fear is there, but based on what I've seen, you know, socioeconomics isn't doing it. You know, maybe, and this is what our hope with the doulas, with the doula project, is that maybe stress reduction is enough. Like, I hope I'm wrong. I love to be wrong. I hope that Kuzawa and Sweet are wrong too. Hell, I even hope that Nancy Krieger's wrong. I hope that maybe embodiment is just something that seems like it should be. And from a social justice standpoint, I also like embodiment, and I like the idea of the epigenetic piece, because it means that our society doesn't get off the hook for crimes against humanity. It doesn't get off the hook for it. We don't get to say, well, that happened a long time ago, so that's over. It's like the past isn't even the past, I think someone said. It is with us all the time. You're here because your mom and dad met. That's how you got here. If you didn't get here through that route, please let me know, because I want to do a study on you, okay? The past is important, and things that happen in the past have a disproportionate impact on the present. And so that's the other reason why I like it, but I do recognize and respect that that is a potential issue. Shannon.
Nancy asked my question.
Oh, okay.
But can I just tweak it a little? So you're talking about using these life histories as a way to capture that, but as you frame it, you're talking about proximal embodiment a lot, or microaggression. How do you conceptualize thinking about these historical legacies? Because they are important.
Yeah, I mean, that's the toughest piece of it. And the way that I have tried to think about it is through a process of elimination. And say, okay, if we have someone, if we can start to identify these individuals that they don't have even perceived racism is very low. If they have fairly high socioeconomic status and have for generations, for multiple generations. If they live in a community of folks that, you know, where they feel very supported, where their education level is high. I mean, I think you sort of, it's the process of elimination, right? If you look and you see that they didn't grow up next to an incinerator or a refinery, if they had all of the other socioeconomic pieces that we know matter for health in every other context, then what are we left with? What are we left with, except for this? Now, you know, it's a bit of a sort of, you know, deductive way of viewing it, I suppose, right? But I think it's almost all that we have right now, since we can't step back in time. But, you know, that's where I'm at on it. I'm still trying to struggle with it. I'm learning with this as well. So, Vicki, you had something as well?
It was on your last slide, Ron. So you were hoping that we do study what these pathways are, the very last slide, I think, of your presentation.
Okay.
Unraveling the mechanisms of of embodiment.
Yeah.
We saw the recent AJPH issue that is all about the epigenetics and how this is happening.
Yeah.
And then this conversation on social justice. One of my fears is that because as a society we are so fascinated with medical care and
Yeah.
genetics and the genome and so much money going into all of that, that we as a society will put disproportionate amount of resources towards that end and far less on the social justice piece.
Yes.
We've seen this with the social determinants of health, certainly, that imbalance of resources. And I'm just fascinated with the biology of race. And
We are. The biology of race, yeah, we love it. In America, we love it, yeah.
we do. And there are people there that are happy to write those grants and do that research.
Yeah.
So I wonder how you think about that balance and how do we, as those of us who are much more interested in the second than the first, how do we ensure that remains a forefront part of the conversation?
Yeah, I mean, so the concern is how do we ensure that we don't focus so much on the sort of fun technological elements of the genome and of which epigenetics is of course one, and not lose sight of the social justice issues that effectively underlie what we're talking about here. The only answer I have for that is that those of us who are in this game and who understand the social justice aspects of it, that we never let people forget it. That we never let them forget it. One of my biggest fears, and I kind of intimated this a little bit in trying to answer Nancy's question. One of my biggest fears is that we're going to come up with a pill, right? Oh, it turns out that all you have to do is ensure that some vitamin is super concentrated that black women can take, and boom, now their babies are living and everything is good. Aren't we wonderful? Right? Aren't we wonderful? That's one of my biggest fears. Because again, I do not accept that we should be allowing ourselves as a society to get away with what we have done. I don't, and that's a normative thing for me, right? I mean, that's, you could argue, hey, if the past is the past, let sleeping dogs lie. Yeah, okay. You can argue that, but in what other context are we okay with that, right? I mean, murder has no statute of limitations, right? I mean, why should this? Why should this event these events that have happened in the past that have never been properly addressed and that worst case scenario that we see today are impacting the health of people who even have healthful behaviors, right? I mean, why do I have hypertension? I can't figure it out, right? My mom was at her thinnest point and all of a sudden she passes out at work. Oh, ma'am, you have hypertension. Why? Right? I think that is what drives me. It's the commitment to ensuring that we don't get away with it, that we address what we've done as a nation, because that's ultimately what will help bring us together in the future. And I think that's the only answer I have. That and, well, that's not true. That and trying to do things like doulas and hoping against hope that they work. Because at the very least then, we can start to create new connections with people. And it can be cheaper, and we can say that, oh, maybe we should do childbirth differently, right? Because a doula is the anti-technology, isn't it? I mean, that's an anti-technology. Oh, it turns out that you don't need a NICU. What you need is a woman who says, honey, it'll be okay, come on, I'll be here with you the whole time. It turns out that that's all you need is love. So yeah, that's my smart alecky answer to it. Sonia.
Yeah, not to be contrary, but
Be contrary, please.
the baby's gonna be no birth weight. It doesn't matter how many doulas you have. That's not gonna change that. But other than that,
No, well, we don't know. We don't know.
one of the biggest questions that you ask is how do we measure environment? How do we measure what's happening? And I think one of the things that we don't talk about is the perpetrators of those microaggressions.
Oh, yes. That's right.
And not only at the individual level, but at the policy level, because we know through studies and evidence that there have been periods in our history where the health of black people was better because of the policies that were different at the time. So that's one point. So one of the things that how do we measure is we triangulate, because it's really difficult to just measure individual experiences, especially if you're going to talk about perception of racism. So the experiences that are devalued in this society are the experiences of people of color. But we need to measure more the experiences of the people that are causing those aggressions and the policies that allow that to happen.
Double thumbs
and
up.
I think if we triangulate that way, then the mixed method part comes in, because you do it within policy studies. So you can easily study that and then look at the experiences and also the experiences of the people that are continuing to perpetuate the discrimination and the racism.
Absolutely. You know, I'm glad you brought that up, because it reminded me of another thing as well. But one of the things that, that I'm doing in Beloit, because it has a high black infant mortality rate, and that group that I mentioned before, the Beloit Life Course Initiative for Healthy Families, we are trying to do a training for medical personnel at the hospital. And that came about through qualitative data, right? Before I got there, they had done a study, that organization did a study asking black mothers throughout the community, you know, how did you feel when you went into the hospital? And based on it, you know, almost to a person, they were like, I feel like I was disrespected, I felt like I was mistreated, and so on and so forth. And so we're actually now working on trying to do some sort of training for the intake staff, right? The docs, the doctor said they could give us 15 minutes. And you know, fair enough, right? They're busy. But so one of the things we're struggling with is trying to figure that out right now. But that's exactly it. It's not enough for me to say, you know, sister, we need to help you to calm down. What we need to do is we need to ask the hard questions of the people who are stressing you out to begin with. And so that idea that we need to triangulate, and we're not even talking about policies per se, right? We're talking about trying to get people to acknowledge that you're treating people differently and they're perceiving it and it's impacting their health, right? Woman goes in, she's having pains, and someone says, well, you know, we're not going to be able to see you today. And so she turns around, goes home, and has a preterm birth at home, right? Things like that. So absolutely what you're saying is that we have to think about triangulating this, right? And when it comes to policies, we know that policies are having an impact. This food stamp policy, recent changes to food stamp, this is gonna matter to some people. This is gonna really matter. Just like I actually found in my dissertation. The End of Welfare as We Know It by Bill Clinton, you know, he signed it into law, so it's his. Yeah, we saw white infant mortality rates creep up after that. People don't talk about it. So yeah, absolutely, Sonia. Anyone else? I mean, my young people up here, I mean, am I just that enthralling? It's just, I have no questions.
Oh, no, just, we don't want to.
Oh, no, you're supposed to say, yes, you are, but no, please, do you have any questions? By all means, please, feel free to ask, go ahead.
Perhaps just because we don't have socialized medicine in the company, in America, these days, that could be another factor of stress on somebody, not knowing that not only are they going to have a blessing of a baby coming to them, but they're also going to have a substantial hospital bill afterwards. If we were to have some form of socialized medicine, possibly just to reduce it, would that factor in to having an effect on?
Okay, look, so here's the thing, right? Access is a part of it. It is a part of it. But it's not the biggest chunk of it, right? Because what we have consistently found is that many of these inequalities that we see, these health inequalities, they still exist even when people have the same insurance, right? A lot of the studies that I'm familiar with have been done looking at Medicare, right? Everybody, you know, you reach a certain age, everybody's on Medicare, right? And so you see access is not an issue for them. Everybody can go to the doctor, and the VA system is the same. But we still see the disparities in the system. And we think that part of it is provider effects, right? The sort of things that I'm talking about and that Sonia mentioned, right? But another part of it is still something else that's there, right? And we can talk about it being either proximal embodiment or life course embodiment, right? But there are other pieces as well. But access would absolutely matter, right? I cannot tell you all. I had both of my kids in a socialized medicine system, right? Both of my children are Japanese, and I can't tell you the relief that came when I went to the doctor and found out my wife and I were getting paid $1,000 to have our first child. Man, you know what that does to you? You walk out of the doctor's office like, man, you know, we're going to buy some of this. I mean, it changes your mindset. It does. It really does. So there is that. That certainly would matter. But, you know, we also do have to keep in mind, too, that's a long haul plan. And so I'm always, you know, as much as a dreamer and a sort of, you know, angry man all the time that I am, I also try to be a pragmatist. And that's one of the reasons why we're trying to focus on like doulas, things that yeah, it'd be nice if we can get the whole society to understand the social justice element, but we need to do something right now because this is not right. So, but good question.
So why don't we end on a high note?
All right.
In the context of time, please join me in thanking Dr. Nikora for a fabulous conversation.
Thank you. Thank you very much, Gary. Thank you all. Had a great time.